Hello everyone. This is I think it's already the 5th edition of our SECEC user combined webinar we're organizing this year again. We already had a webinar on rotator cuff, frozen shoulder, stiff elbow stiffness, shoulder arthroplasty, and this year we're at the elbow arthroplasty. I wanted to especially thank Jagwant, Singh, and Val Jones for putting together a very nice program, if I would like to say so. And combined with all the members of the healthcare delivery committee of the SECEC and all the members from EUSSER to help us out. And this webinar is being recorded, so you can watch it later, the replay on the SECEC site. On the SECEC app, you can find it underneath the webinars, and you can also find it on the EUSSER website. One of the practical point, if you have questions, you can do that via the Q&A section down below in the Zoom agenda. If you want to say, hi, I'm here from Berlin or this and this from Spain and I want to join, for those kind of comments, you can use the chat function. So those were the practical things. Let's start with our webinar. The first speaker is going to be Denise Eygendaal. She's from the Netherlands. To me, she already was, Denise is Miss Elbow when I started with my residency. So she's going to tell us a lot of things about the elbow. She's now the current head of the orthopedic department in Rotterdam, where we will be having our SECEC conference next year. And Denise will tell you all about the key concepts and principles of radial head arthroplasty.
Dear elbow friends, it's a great pleasure to be the first speaker in this webinar. Thanks Tjarco Alta to organize this on an important topic, let's say dysfunctioning of radial head prosthesis and total arthroplasty. So I will focus on the key concepts and principles of radial head arthroplasty. We should not think that we are innovators or early adapters or hip and fancy if we're talking about radial head fractures, because Paul of Egina already talked about radial head fractures in the 7th century. Moreover, the first report on radial head arthroplasty were done in the Journal of Surgery, Gynecology and Obstetrics. Actually, I have never published in that kind of journals in 1941 on the, let's say, the first generation of radial head arthroplasty. And it's amazing, a lot of implants have been released last 20 years and even more implants have been taken off the market. And we also know that sometimes with very easy things as using cement you can make a patient-specific radial head implant. So realize that every design of a radial head implant is related to certain complications. You can have malalignment, you can have erosion of the capitellum, dissociation of the radial head prosthesis. You can have dissociation of long-standing prosthesis after polyethylene wear. And you can have symptomatic polyethylene wear without dissociation. And of course you have loosening. And realize that if you have a subcapital loosening, that is not symptomatic, that is physiological. So in most, especially uncemented stems, you see subcapital loosening, which will be stable within 2 years and doesn't give any symptoms and is not a reason for revision. If you look at the numbers of radial head placed, they are increasing. So are the numbers of revisions. If you look at the numbers the last years, it's definitely increasing between 2007 and 2011. And the most important question is, what is the revision? What is the reason for revision? And if you look at the brown arrows, it's sometimes overstuffing, and that is a technical failure that is surgeon-based. Sometimes it's early loosening or instability, and that might be surgeon-based as well. And realize that the complication rate of a radial head prosthesis is up to 30%, so it is not a very forgiving implant. If we talk about key principles of radial head arthroplasty, we first have to talk about the anatomy and biomechanics of the native radial head, a lovely structure. If you look at the blood supply, it is very brittle, so it is prone to avascular necrosis. Realize that the radial head is elliptical in shape, it's not round. And the annular ligament encircles the radial head, and it's from the ulna to the ulnar and gives stability to the proximal radial joint. And know that the radial head is an essential factor in longitudinal stability and load transfer. And of course, the radial head tensions the LCL. It's very difficult to optimize tensioning of the LCL without a radial head. And realize the load transfer depends on the amount of extension, of the amount of valgus, and the amount of supination. Like in this case, there has been a resection of the radial head in case of MCL or UCL insufficiency, but finally results in tremendous instability of the elbow joint. And yes, those radial head prostheses can restore stability, and I come to that later on. Realize that if you make a micro CT scan of the radial head, that the anterolateral part and the posterolateral part are weaker than the posteromedial and anteromedial part. So this is the weak part of the radial head. And if you do mapping, a heat mapping of the radial head fractures, most of the fractures are on the ALPO part. If you look at the study of Lars Muller and co-workers, we know that it's almost impossible to generate a radial head fracture without any injury to the IUM, to the intraos membrane, especially the central band. Sometimes you're during your surgery struggling with the replacement of the native radial head, and I think you always try to replace or restore the native radial head. And you're not exactly know how to replace it, the native radial head, and realize that the cartilage on the articulate part is much larger than on a non-articulate part. So if you're in doubt, look at the width of the cartilage, because that determines which part is on the outer side of the osteosynthesis. And that non-articulate part is just opposite to the radial tuberosity. So that can help you out also during surgery. And I would love to drive some attention to this paper. It is on replacement of the radial head after an on-table reconstruction as a natural spacer. And I think that really is a good alternative, especially in young patients, to prevent radial arthroplasty, because we know 30% of the radial arthroplasty will have some complications. So how are we going to replace the radial head? First of all, it's on indication. So it's a smashed head. We try to remain the native radial head, and you need to have associated injury as MCL injury, IM, etc. Supine position, your forearm in pronation, so you're moving away the radial nerve from the surgical field and prevent neurological injuries. Prevent overlengthening, so never replace more than you resect. And there is a difference between over-lengthening, that's the height of the prosthesis, and oversizing, that's the width of the radial head. If it's too big, it will rub on the LCL and give insufficiency of LCL. If it's too high, it will overstuff the medial part of the joint and result in early osteoarthritis. So if you're talking about the size of the head, preferably take a smaller size. If you're talking again about the neurological issues around the elbow, you know that the PIN is fixed to the radius 4 centimeters distally from the radiocapitular joint. Realize that there is an angulation of the shaft around 15 degrees. So if you have a long stand implant, you have to take this angulation into account. And realize that malpositioning, especially with shorter implants, is common. And that a shorter stem goes into the radial tuberosity. And you can prevent this with fluoroscopy. Like these two cases, there is a malalignment, and you can use fluoroscopy to realign your distal short stem implant in the direction of a distal radius. Realize that over lengthening, so the height of the implant cannot be corrected by fluoroscopy, nor it can be controlled by fluoroscopy. We know that from studies from Graham King, the only anatomical landmark during surgery for the height of the prosthesis is not the capitellum, because most of the time the LCL is gone, but it's the upper part of the lesser sigmoid notch. So if it's too short, it doesn't contribute to stability. If it's too long, you've got increased pressure with accelerated osteoarthritis of the ulnar part. So you have to align the length of your prosthesis in relation to the height of the lesser sigmoid notch. This is essential. Realize if you use an implant which is elliptical in shape, that it is related to the right orientation, important. And realize that if you use an implant which uses screws for fixation, do a proper tightening of the screws, because it might back out easily and then you can have dissociation of your implant. And yes, this is the radial head prosthesis of Graham King with an intentional loose fit, which has the best outcomes so far in the registries. So if you're not very experienced with radial head prosthesis, choose for the simple modular unipolar system. And then again, should you choose for unipolar or bipolar, we know that that bipolar design improved the radiocapitular contact, and especially in long-standing post-traumatic deformities like this one, you often see a medialization and a posterior migration of the proximal radius. Then you're probably better off with a bipolar implant because it can correct for the malalignment. We recently wrote a paper on the dysfunctional radial head prosthesis in the effort Open Reproduce, and you can see all the steps, but I'm convinced that the next speakers will address all these topics as well. So again, thank you for listening to this webinar, and realize there's nothing better than your own radial head. Enjoy the rest of the webinar.
Thank you very much, Denise, for your very practical and basic instructions and talk. We will continue with the next talk. It's from Lee from Rensburg. I looked up your resume, Lee, and I saw that you are actually from South Africa, from Joburg, and that you also did a fellowship in the Alfred Hospital in Melbourne, and are now working in Cambridge, United Kingdom. And Lee will enlighten us all about painful, stiff radial heads.
Thank you for giving me this opportunity to discuss the painful and stiff radial head. Here are my disclosures, none pertinent to this talk. It's easy to blame this radial head as the cause of pain and stiffness. When you see that massive widening of the lateral facet of the ulnohumeral joint and medial subluxation of the elbow, it's clear that this radial head is the cause for the patient's pain and stiffness, and revising that radial head is likely to improve their symptoms. Not so easy in the 61-year-old male. Is this radial head overstuffed? Is this radial head the cause of the lack of pronation and supination? And then our eye is drawn to the lateral radiograph and we see the radial ulnar synostosis. And it's not the radial head that's stopping the pronation and supination here, but the synostosis between the radius and the ulnar. Is this radial head overstuffed? Be careful using the lateral ulnohumeral joint widening as a criteria for overstuffing. Points 1 and 2 are not always the same as points 3 and 4, and points 1 and 2 are not always parallel. Atwell and King went on to suggest that possibly medial joint space loss of parallelity is a better indicator of overstuffing. But in their surgical technique, they talked about the fact that you have to be overstuffed by 6 millimeters before you lose that parallelity. They went on to show this radiograph, which shows an overstuffed radial head, but with the patient being minimally symptomatic. And so you can't always be sure that your overstuffing is the cause of your symptoms. It is possible to work out the height of the radial head to within 1 or 2 millimeters with 4 steps. You get standardized radiographs of the normal and the radial head side, and then measure the markings on both radiographs. In essence, you place a point on the humerus on the most lateral aspect of the ulnohumeral joint, on the ulna on the most lateral aspect of the ulnohumeral joint, and join that to the most medial aspect of the coronoid. You then bisect the radial head. Watch out, different radial heads have different stem shapes and angles. Here we see a chamfered stem. You basically want to bisect the radial head, and you can then measure radial head height and compare that to the. Here we see a 27-year-old who has stiffness 1 month post-op. They have an arc of flexion and extension from 45 degrees to 90 degrees. We see the initial radiographs at 2 weeks and the follow-up radiographs at 1 month. Comment in the notes from the surgeon. They thought the radial head was too big, and that was the cause of lack of movement at 1 month. They went on to excise the radial head and do an interposition anconeus graft. Notice the widening of the medial facet of the ulnohumeral joint. That medial collateral ligament and common flexor origin injury hadn't totally healed at the time that they were taking out the radial head. Fortunately, the elbow remained in joint, but we see the radiographs at 6 months with no improvement in pronation and supination. And by 18 months, we have an arc of movement of 15 degrees to 140 and very little pronation and supination. I like to look at the initial radiographs, seeing the severity of the initial injury. We see how this humerus has been shunted down the forearm, how the radial head is halfway down the proximal radius. We see a terrible triad with a significant coronoid injury. It's not the usual intermediate ridge piece, which would be the Wrightington B+, the bifacet coronoid. This injury has injured the medial collateral ligament, common flex origin, common extensor origin. And I would suggest it's that soft tissue injury is the reason why the elbow was stiff at 2 months and not the radial head's fault. Denise Eygendaal showed us the significance of the medial injury leading to more stiffness and more pain. When we look at the initial radiographs, we see, for me, what would be a good radial head in terms of height and diameter. Is this radial head overstuffed? We see here how the radial head projects proximal to the lateral aspect of the coronoid. There's no change in the widening of the joint spaces. And the problem here is it's important that you get your radiograph tangential to the radial head. We see how the intraoperative films, the height of the radial head is absolutely perfect in relationship to the lateral facet of the coronoid, and that this is not overstuffed. One of the problems in the stiff elbow is that the radiographer splits the difference and takes the radiograph on a slightly flexed elbow, which projects the leading edge of the radial head more distal. It's important that it is tangential. It's also important to remember that the radial head moves proximal in supination and distal in pronation, and most times when we're doing our intraoperative radiographs, we do it in full supination. Coming back to that 61-year-old, where I said I wasn't sure if this radial head was overstuffed, we see how the radial head is projecting proximal to the chronoid, but it's not a perfectly tangential view of that radial head, and we now know that you can't use lateral facet ulnar-humeral joint widening. One of the problems with intraoperative fluoroscopy in assessing radial head height is we don't account for the cartilage. And that's why it always looks like it's a little bit proximal and a little bit too wide, because we don't account for the 2 millimeters of radial of cartilage in terms of assessing height. This study is putting a little metal marker where the cartilage would run and suggesting that this would be the perfect intraoperative radiograph to show you height of your radial head. It also explains why it always looks a little wider than you expect. The capitellum sits in the cup of the radial head, and the radial head is not a perfect circle. It has a different anterior, posterior, medial, lateral diameter. The best way to assess radial head height is to look at the relationship between the radial head and the lesser sigmoid notch. And there is no better view than Boyd's approach to be able to see the relationship of your radial head to the lesser sigmoid notch in trauma or for elective arthroplasty. It's a modification of the Riet approach. Don't osteotomize the supinator crest unless there's a big enthesophyte in the supinator crest, but you get to see beautifully the relationship of the radial head to your. Sometimes the stiffness is not the radial head's fault, it's the surgeon's fault. Here we see a radial head replacement done with casted for 4 weeks at 30 degrees. And at 6 months, no surprise, they have an arc of movement of 25 degrees. Did the surgeon look you in the eyes and tell you, I know it hurts, but you need to move it? Replacing the radial head is only the first step. The next step is the importance of getting it moving, otherwise you will get stiffness. Sometimes it's not the radial head, but it's the surgeon. Be careful blaming loosening as the cause of your pain and stiffness of your radial head. It's not uncommon to get loosening, which is minimally symptomatic. When we have a look at the initial injury, we see how the radial head is tucked underneath the medial epicondyle. This is the hyperpronation injury. They've torn the medial collateral ligament in common flexor origin. At 5 months, this patient had developed a sinus with loosening of the lateral anchor. On intraoperative screening, the surgeon found that the medial collateral ligament had healed or remained intact after removing the high-density polyethylene and the anchor on the lateral side. But the elbow wasn't perfectly congruent coming into extension, and certainly if they'd excised that radial head, I worry a little that that elbow may have redislocated. And as such, they undertook a DARE procedure. Here we see the radiographs at 6 months with the loosening, and the sinus reopened at 18 months, at which time the radial head was removed. If you need temporary stability or to keep the space, it is possible to make radial heads out of a syringe. Wiring 2 syringes together, you're able to make different stem diameters and different stem heights. You can fine-tune it with an ET tube. And we're now into the world of arthritis as the cause of pain and stiffness. We see a 27-year-old who had a radial head replacement at the age of 16 with an arc of movement from 0 to 150. And when we play the sagittal films, we can see the marked ulnar-humeral arthritis with peaking of the chronoid and the tip of the olecranon and radiocapitellar arthritis. And now we really are in the realm of arthritis and the treatment of arthritis more than the treatment of the radial head. She had an anterior capsular release. And here we see her radiographs 2 years post-arthroscopic debridement and ulnar nerve decompression and 10-year follow-up. She's now 37, but again not symptomatic to warrant any form of ulnar-humeral arthroplasty. Thank you.
Thank you very much, Lee, for your very illustrative talk with nice pictures and videos. Just a short comment for all the participants. If you have questions, please place them in the Q&A section in the below part of the Zoom agenda, because then we have something to discuss after this first session. The next talk will be from Roger van Riet. I know Roger already a long time. We go way back. And Roger will be our next president of SECEC coming in September in Munich. and he's a professor in Brussels, in Belgium, and he's also working in AZ Monica, which is in Antwerp. And Roger will tell us how to revise a radial head replacement.
Hi, my name is Roger van Riet, and I'll be speaking about revision radial head replacement. I do some disclosures. I'm a designer of the Exo Elbow post-operative brace by Jake Design, and I'm also a designer with Acumed. In this review paper of over 1,000 patients, 77 had been removed and 45 had been revised after a follow-up of about 38 months. The highest rate of failure happened in the first 2 years, and 10% of these patients had been revised or removed. Main reason was HO, followed by stiffness, pain, loosening, overstuffing, instability, infection, and component disassembly. So why do these fail? In a study that we published in 2010, this is the Mayo experience, not my experience, we found 47 patients, 40 of them had pain, 18 had stiffness, 9 had instability, and 2 had an infection. Loosening was found in 31 patients, over-lengthening in 10, radial subluxation or instability in 5, and component dissociation in 3. And we looked at the different prostheses. We found that degeneration was more prevalent in bipolar prostheses than in loose stem uni, and less prevalent in the fixed stem uni. So the fixed stem, press fit or cemented, with a non-bipolar head, actually had a lower rate of degeneration. This table shows the differences. So stability, rigid and bipolar, although bipolar is less stable in the lab, it didn't really make a difference in the patients that we followed. Orientation was better with bipolar, so some of them had subluxed or dislocated, and that happened only in rigid. Range of motion was better in bipolar, but degenerative changes we found more in bipolar prosthesis when compared to rigid prosthesis. Now, what if it fails? These are, I think, the options. You can just remove the prosthesis with or without interposition of tissue, or you can revise the prosthesis. And I prefer to use a long stem that can be either press fit or cemented. In our series, and we'll talk about this later on, I use a cemented long stem bipolar prosthesis. You can also revise the capitellum only if the problem is degenerative wear of the capitellum and not so much loosening of the prosthesis, for example. Or you can use a radiocapitellar replacement. We'll talk very shortly about this because the one that we used to use, unfortunately, is no longer available. We used it in selected patients, obviously when there is capitellar erosion. And Christian Sproos looked at our series, and this was osteoarthritis, not revision radial head prosthesis. But he looked at our series with decent results. However, like I said, it's no longer available because of one of the problems was loosening of this radial head component. So the actual isolated radial head is no longer available either. As far as I know, the LRE system by Joe Pooley is the only one that's available at the moment. But unfortunately has limited indications in revision surgery. So the OA patient may still be helped by this prosthesis, but it doesn't address radial bone loss. So if a radial head prosthesis had already been placed, assuming that the neck was cut and the radial head was removed, then this prosthesis cannot be used. So one of the simplest and cheapest ways of dealing with the failed radial head prosthesis is simply to remove it. This was a silastic one that we removed arthroscopically, and the patient was happy post-op. Knight et al. In 1993, so a long time ago already, said that if you have a metal radial head, you can simply remove it after the soft tissue have healed. So basically they were saying it's a temporary spacer, and some people still use that term, temporary spacers. Once the soft tissue has healed, you just remove the radial head and the patient will be fine. There's not a lot of data on this. Neuhaus published 14 patients, removed for pain and stiffness. All of them had capitellar erosion. 30% had reoperation for ulnar nerve issues, and 36% had ongoing pain. So it's not the best way of dealing with these patients. So ongoing pain was just removing the prosthesis. Kiechler et al. Showed slightly better results. 19 patients, Mayo performance score 73, so not perfect, but maybe not too bad, with a VAS score of 3, and they said it's better than a primary resection. So it's better to replace the radial head when it's fractured, and then maybe resect the prosthesis later on, than to actually resect the radial head immediately. So we assume that soft tissues heal, and this unfortunately does not happen in all patients. This is not, again, not my patient, but Dr. Maury's patient, where the radial head had been in for 4 years. It was removed for pain. It looked perfect pre-op. During the surgery, Dr. Maury assured me that he was pulling it, he was trying to dislocate it. It was very stable, both longitudinally and varus valgus, but unfortunately, although it was stable during surgery, he did develop valgus instability and longitudinal instability, and this ended up in the end in a total elbow replacement. So this is something to be avoided if we can, and this is the reason why I prefer, again, we'll talk about this in a second, I prefer to replace the radial head instead of remove the radial head component. This was a patient where radial head resection had failed. So he had a prosthesis, it was removed, a lot of bone loss, severe pain, severe stiffness, and some instability. And because of the bone loss, we didn't have a system that we could actually use. So we decided, of course, by talking to the patient, to print one of these prostheses. And we used a Belgian company to do this, because they were the only ones that we knew of that could marry the polyethylene of the articulation to the printed implant. We used guides. This is not the topic of this talk, so we'll go over this very quickly. We used guides, and we cemented the implant in place. So these were resections that failed, and Rami et al. Published their experience with interposition arthroplasty. So remove the radial head prosthesis and interpose the anconeus in the gap. They followed 12 patients for about 3 years. Our performance score very good, 87. VAS score low with 2.3, and a nice functional range of motion, but not perfect. And then, somewhat surprisingly, the authors said in conclusion, they're not sure if interposition made a difference. So no one can tell whether it's better just to remove the prosthesis. It might fill up with tissue anyway, or if it's better to remove the prosthesis and interpose with an anconeus or something else. This patient caused a specific problem. So it was a 50-year-old man. He had a radiocapitellar prosthesis placed. 14 months later, the radius component was removed because of pain. An anconeus interposition was performed, and unfortunately, it didn't work. So we had to revise him 12 months later, but we had a problem. The prosthesis was no longer available. So we used a radial head component from another company, and a follow-up of 3 years, he went from a VAS score from 9 to 2. His flexion extension improved a little bit, but protein supination improved tremendously. And the Mayo performance score went from 25, so very poor, to 85 because of the mild pain. And this was a very happy patient. In one patient, we revised the capitellum only. So I thought this was a well-placed implant, but this patient had a lot of pain. And on the technetium bone scan, we saw that the capitellum actually lit up. So the radial head was probably riding into the capitellum. Talked to the patient again, and then we revised it. Back then, Tournier Wright Medical had a head with polyethylene, and we were able to revise the head and then implant a capitellar prosthesis from the same company. And this patient was extremely happy again. These patients are quite painful. So revision options, I've had one patient where I've revised the capitellum only. We printed 2 RCPs, and we had 2 where we had mismatched implants, radiocapitellar prosthesis, the one I showed you, and another patient that was a similar problem. So that's not my standard approach, because this is, of course, very, very rare. Our approach is now, we revise, so we remove the failed implant, or if it's already been removed, we revise with a long stem cemented bipolar radial head. We see capitellar erosion in all of these patients, so what we decided to do was to under-lengthen the radial head, or the radius. And we deliberately shorten it by 2 to 5 millimeters. And the rationale behind this was that they will still have somewhat stability when they need it. So when they're pushing on the arm, or when they have valgus stress in the arm, the radial head will still engage, but it won't engage all the time. We use a bipolar implant because rotation-wise, This will rotate somewhat in the prosthesis, of course, and luckily for them, for these patients, this is a pain-free articulation because that's articulation in the prosthesis and it's not rubbing on anything that has already been worn by the previous radial head prosthesis. Tjarco Martino is looking up our results and hopefully we'll get this published soon. We included 20 patients, average age of 50 years. The reason for revision was overstuffing, unfortunately probably something that could be avoided, loosening, stiffness and infection. Pain and rest not too bad, 3 pre-op, but inactivity average of 6. One patient had 0 pain, both in rest or inactivity, and this patient was revised because of stiffness. Post-op average 1 and 2, so this was a significant improvement from the pre-op pain. Male performance score also improved from 61 to 91. Patients gave a score of 9 on the satisfaction scale and 9 when they were asked if they would have surgery again. And all these patients would have had surgery again. Flexion extension improved a little bit. Pronation, supination improved a little bit more. And this is an example of a patient that we included. So 48-year-old female, had a radial head prosthesis 17 years before, had 4 surgeries after that. 3 years after the prosthesis, so 14 years ago, the radial head implant was removed and another surgeon re-implanted 1 year before we saw her. She had pain in wrist and elbow. Male performance score 50, VAS score of 7, flexion extension relatively stiff, prosupination well preserved. And this was her CT scan, and you can see, unfortunately for this lady, that there's severe ulnar-humeral degeneration as well, maybe because of the prosthesis being over-lengthened a little bit, and this was supposed to be an intentionally loose fit, which obviously is not the case. Just 5 years follow-up. Male performance score is 85, came from 50s, came from poor to good. The VAS score is only 2, she's very happy with this. The flexion extension arc have more or less stayed the same, 35 to 145, whereas before it was 40 to 120, and prosupination stayed the same as pre-op. But again, quite a happy patient. This is now our preferred and standard technique. So in conclusion, failure of radial head replacement happens in 10% of patients. In the majority, it'll happen in the first 2 years post-operatively. There are different options after the failure, but my preference is to revise and underlengthen. In the series that we have now, they have good functional results, low rate of complication, and a very high satisfaction rate. Thank you.
Thank you very much, Roger. Nice overview and a very good summary at the end to everyone to understand what you've all been saying. And the next speaker is going to be Ben Hughes. He's from the UK, from Manchester, if I'm well informed, and he's also working at Riet Hospital. And he's a physical therapist, and he will tell you all about how to rehab the patients after they had a radial head replacement.
Good evening, everybody. My name is Ben Hughes. I'm an upper limb physiotherapist based at Riet Hospital in the UK. And I'm going to spend the next few minutes talking to you about rehabilitation following radial head replacement surgery. Our institution is located in Wigan, which is in the northwest of the UK. And Wigan is famous for rugby league and pies, and indeed the World Pie Eating Championships were held in Wigan in 2023, and you can see the winner there in the bottom left-hand corner. And when you go to the rugby in the UK, you can have a beer or two while you're watching, and if you combine the pie-eating rugby league fans of Wigan with a touch of alcohol, some steep and slippery stadium steps made from concrete, you might end up with a significant elbow injury such as the ones we're discussing should you fall down them following some overzealous celebrations. And I'll talk to you about the rehabilitation considerations following such an injury. We're going to go through these main areas. We won't dwell too much on structure as this has been covered expertly in previous talk. We're going to talk about early mobilisation, onto strengthening, and cognitive and contextual factors that we need to be aware of. If we get all of those things right, hopefully we're achieving a good outcome at the end. Now, these injuries are usually high energy injuries, certainly in the case of our Wigan man falling down the stadium steps, but there are also another group of people who with a relatively lower energy force can still suffer significant elbow injury, and those would be the cohort that are osteoporotic. And they're often associated bony and soft tissue injuries with these radial head fractures, and this includes elbow dislocation, coronoid fractures, olecranon fractures, and medial and lateral ligament injuries. And the literature will suggest that there's anything up to 80% of this cohort will also have an associated lateral ligament injury. So it's important to bear that in mind throughout the rehabilitation process. There is a lack of robust studies into specific rehabilitation protocols following this injury, but those that have been published and been looked at in reviews tend to show that in general people are immobilised for anything up to 10 days following this injury, but there's a general consensus that early mobilisation is key. A sling is essentially used for comfort unless the other associated injuries necessitate a longer period of immobilisation. And that's when communication with our surgical colleagues is important to understand surgery that's been done and any concerns they may have over tissue quality. So when it comes to early movement, we want to try to balance the tissue healing whilst avoiding stiffness. So other things that we can do include using the hand, wrist and shoulder movements early, utilising the crossover effect of the opposite arms. This has been shown to have a good impact on the impacted side. And whether you've had a stroke or you're a Major League Baseball player recovering from injury or surgery, lower limb strength has been shown time and time again to be important in optimising upper limb function. If you are in a sling for a period of time, it's important to come out regularly, little and often, to do movement exercises. And in terms of progression, we would encourage milestone-driven protocols rather than time frames. And I think milestone-driven protocols do encourage us as therapists to think about things such as tissue quality, healing times, and end goals, rather than just becoming a bit more autopilot and reverting to multiples of 4 and 6 within the context of a busy clinical caseload. So there are many benefits. We can get quite detailed here, and we haven't got the time to. But essentially, early mobilisation, is trying to reduce stiffness by optimising the biochemistry that's happening in the elbow. Essentially, we're trying to influence the cascade of neuropeptide to mast cell to myofibroblast formation, and traumatic injury to the elbow activates this normal process of connective tissue repair. But in some at-risk patients, this pathway does escape the normal regulatory process, and it's important to note that this can happen within the first 2 weeks. So identifying this group early is important, and we will come back to this point. When it comes to strengthening exercises, the overhead supine position you should be all aware of. This overhead position is safe, reduces bicep activity, and it also promotes stability in the elbow joint. As we previously said, we want to include the hand in daily function, and it's important to avoid any positions that may place stress on associated ligamentous injuries of the elbow. And we've previously mentioned the high rate of lateral ligament repairs in this cohort, and therefore we'd want to avoid a various stress position in this group, and that's essentially long lever positions in shoulder abduction. Now, general principles of strengthening to follow tend to go from closed chain short lever positions or open chain long lever positions, low weight controlled movements to increased weight and increasing speed, and then getting into sport and activity specific movements further down the line. And it's important not to forget weight bearing and impact work in this in preparation for people that may be returning to higher level function. Now, we promote active elbow movement rather than passive elbow movement, and this study that came out last year I think further adds to the bulk of evidence, in my opinion, that moves us away from entertaining anything passive really. And this study, although it was small and looking at various pathologies and surgeries, does show that there's seems to be a co-contraction at the elbow seen on passive range of movement exercises, predominantly at the end of flexion and extension, and it's more intense in chronic cohorts. Now, it does ask a few more questions as to pose a few more questions as to why, whether it's a normal protective mechanism or is there some chronic adaptation of an internal, reflexive muscle splinting mechanism in the elbow. But again, to my mind, it just adds further fuel to undertaking more of an active movement approach and avoiding any passive elbow movements and certainly any stretches in the early stages of rehab. From a cognitive and contextual point of view, identifying those that may have a poor outcome is key, and we mentioned that a couple of slides ago. Anxiety is common and has been shown to be linked with a subsequent disability, along with depression and with stress. And there are also well-documented links between litigation, psychological distress, and a reduced quality of life following orthopedic trauma. Now, along with anxiety and depression, a fear of movement or kinesiophobia that's identified within the first 4 weeks is strongly correlated with a poorer outcome at 9 months. And that's important because we've got a biochemical cascade contributing to stiffness that can be happening within the first 2 weeks, and now we've got a fear of movement that, if identified within the 4 weeks, is shown to have a poorer outcome at 9 months. So it's really important that we identify these people earlier. And I think another key difference for us to be aware of is, when we're having an elective procedure, we've often got some time to do some pre-rehabilitation or prepare and optimize people for surgery if we feel that they have some risk factors. But following a traumatic event, it's completely unplanned. And there's a lot of evidence now that certain individuals are primed for a problematic pain response, whether they've had an RTA and are suffering from whiplash, or they've got an acute episode of back pain, progressing into more chronic low back pain, or whether they've got another associated orthopedic injury. So some strategies to use with this challenging group, or this group that has shown that they might have a poor outcome. We could consider the use of graded motor imagery, which is a 3-pronged process, going from right-left laterality through to motor imagery, finally consisting of mirror therapy. We can use compression, tactile input to help with proprioception. That can be anything from a compressive sleeve to manual therapy. Just having our hands on a patient and facilitating movement can be very, very useful. And manipulating the context can be key as well. So we've heard Val talk previously about using patients' favourite music in the rehab process. You might try to better understand the context that the patient's living in, their support networks, their job and their social context. If they spend a lot of their time preparing food for their family, then incorporating some of that meal prep into their rehabilitation protocol is going to be much more likely to gain traction than maybe some exercises and movements that they're unfamiliar with. And the other thing to consider is, if you've got a difficult patient that's slow in rehabbing and showing some signs that they may be a poor responder, having regular appointments near the beginning or longer appointments to try to understand this better can be crucial, and it's important to do that early rather than at a later stage. So in summary, we need to understand the surgery that's been done. So communication with our surgical colleagues is important, and particularly any associated soft tissue injury. We need to be aware of any restrictions in movement as part of the ongoing rehab process with that cohort. Early active movement is key, and we've got to try to catch the challenging cases early. Things like fear of movement, kinesiophobia, anxiety, depression, high levels of pain may indicate that you have one of these cases on your hands, and in which case spending the time with them, seeing them more regularly, longer appointments at the start is likely to have a much better impact on their outcome further down the track. And to use one of Joe Gibson's phrases, cognitively rich rehab may help you with this group. So tactile input, reassurance, and empowering them to take ownership of their rehab can all be really, really useful. Thanks very much for listening.
Thank you very much, Ben, for taking us through your rehab protocol and also making us aware again that the elbow is also attached to a person and that you take that in consideration with your rehab as well. We're going to do the Q&A section. Jagwant, Singh from the UK, together with Sjaak, Kodde from the Netherlands, they will moderate this session. So Sjaak and Jagwant, take it away.
Yes. Thank you, Tjarco. The first question I want to put to Denise Eygendaal. This is from Veronica from Mexico, and she would like to ask, what is your preferred measure to evaluate overstuffing and or right placement in a primary radial head prosthesis?
Well, that's a good question. And first of all, during surgery, again, fluoroscopy won't help you out. So during surgery, it is only the lesser sigmoid notch, which is a safe and reliable landmark. And as Rens told us, it is best seen by the Boyd approach. If you do an assessment of a post-op dysfunctional radial head prosthesis, then we do, first of all, a workup of an X-ray of both wrists, AP view, to rule out proximal migration of the radial head prosthesis. So that is a proximal migration of the complete radius, because that's, of course, different than an oversizing, over lengthening of your prosthesis. The last one, if there is an equality of the distal radial ulnar joint of both wrists, and there is a narrowing of the joint space of the medial side on the AP view, then you probably have to deal with an over-lengthening of your prosthesis.
All right. Thank you, Denise. That's quite clear. So the next question I would like to ask to Roger. It's from an unknown participant. Roger, what would you say is the advantage of the stability from under-lengthening in revision cases, of course, over-excision of the radial head prosthesis and then do an interposition?
Thank you, Sjaak. There are two possible advantages. One is that, first of all, the radius and the ulnar will not collapse into each other. So rotation-wise, it makes it much easier, and that's why I use a bipolar prosthesis, so it actually moves in the prosthesis itself, decreasing potential pain from windshield wiping of the radius to the ulnar. And secondly, we know from Dr. Morris' work that when you resect the radial head, the physiological give in the system between radius and ulnar is about 2 millimeters. So that means if you understuff it by 2 millimeters, there will be potentially, I've never proven this, but potentially there will be moments when you, for example, grip, or when you're loading the elbow or the forearm, that you still get contact between the radius and the capitellum. So you will decrease the valgus stress, and you'll decrease the stress on the interosseous membrane and on this radial ulnar joint. And that's basically the idea was born out of necessity, because Stryker got rid of the radial capitellar joint, so we didn't really know, or joint replacement, so we didn't really know what to do next. And for me, the ankle-knee interposition never worked very well. Same as what Lee showed us. I had some patients that we didn't wait that long until the elbow was really worn, but I had some patients where the pain really didn't go away. And so we started understuffing it a little bit to keep the pressure of the capitellum and to hopefully still allow for some stability.
All right.
There is a question from Lee to you, Roger. He's asking you, how sure are you in presence of significant ulnohumeral arthritis that only radial head revision to shorter bipolar will make them better? What are chances you will make them worse?
Chances of making them worse are very little. The progression of degenerative changes has already started, and at the best, I can maybe slow down the progression, but I won't be able to turn around. But most patients are below 60 years old, and if I can, I'll do anything to decrease the chance of a total elbow replacement. So in our series, it seems that this has helped so far in all of them at the moment. I'm sure some of them will progress to total elbow replacement. Of course, then we'll have to see whether putting a radial head prosthesis in the meantime may increase the chance of infection, or may increase the chance of problems, or may increase the chance of instability, because we will have to remove that radial head prosthesis, or at least the head, when we replace the elbow. So we'll see whether I'm compromising the patients, but at the moment, I've given them, most of them, I think the longest follow-up was 9 years, up to 9 years of respite.
Thank you.
All right. A question to Ben from Iwa. In what position of the upper limb do you start the exercises after surgery?
Oh yeah. We'd usually start them with a simple table slide or something, forearm rotations in a comfortable sitting or standing position. So that's where people are mostly comfortable. Tend to be a little less comfortable doing anything in the overhead position, sometimes straight away. So we'd just get them using the table to take the weight of the arm, remove some of the gravity, slide the arm forwards and backwards, and rotate the forearm. I think one of the keys is just making sure that they start their physio straight away. So, you know, the importance of explaining the surgery and reassuring them that they can move it is key. You don't want to leave that weeks and weeks and weeks. So start that straight away, keep it really, really simple, little and often movement, and reassure them that moving is going to be safe and fine.
Hi, Ben. Awesome talk. You know,
Jax.
people in Wigan are very lucky to have you guys, and you can see the post-operative patients in good time. What is your advice for surgeons where, you know, when we refer to physiotherapy, it'll be good few weeks before the patients can make it to their initial assessment? What advice should we give to our post-op patients, what to do in terms of exercises so that they can avoid stiffness?
Yeah, I think you could probably show them, Jags, exactly what I've just said there. Really simple stuff in the clinic room. Make sure that if they're in a sling, that they're coming out of it, and show them those safe positions with the weight of the arm supported, and do it with them. If you can reassure them with any of your sort of images and x-rays as well, and just, you know, reassure them it's robust, I think that's massively helpful, because the last thing you want is a patient turning up to physio a few weeks down the line who hasn't really moved it, is frightened to move it, is sort of avoiding it and using the other arm, as we spoke about, those sort of changes in the brain and the sensitivity starts to change quickly. So I think if they're not having physio for a while, but you've got access to them in clinic, just those simple forearm rotations, elbow flexion, extension on the table, and lots of reassurance.
Thank you.
So I think one last question for Denise. Your conclusion was nothing is better than your own head. Does it mean you have to avoid a radial head prosthesis at all costs, especially in the young patient? So does it also mean you have to do an ORIF for the smashed radial head? Or is there still some place for a radial head replacement, as acute surgery is easier than delayed surgery after a failed ORIF?
Yeah, it's a good question. And I really believe that it's easier to replace a radial head with a prosthesis, with a smashed head, than do a proper osteosynthesis. And it depends on the associated injury, because if you have a complete torn UCL or MCL, then you will have, if you want to have, a rock solid radial head. If you have an insufficiency of the IOM, you want to have a rock solid radial head prosthesis. And if you have, let's say, an osteosuturing of a coronoid fracture, you need that rock solid anterior buttress. So whether or not to replace it in young people depends on the associated injuries. Having said that, I always would try to do an untable reconstruction, place it back in place. Based on the study I showed, although we know it's not a randomized trial, it's just 2 cohort studies. You might just leave the head as, let's say, natural spacer. If you fix the coronoid as best as you can, do a ligaments repair, and the elbow is stable, and then it's always questionable what is stable. You're using fluoroscopy, flexion and extension, and if it dislocates in more than 30 degrees of flexion, then it's unstable, and then you need to think over again which structure needs more stabilization, and then it is probably a good idea in younger patients also to place a Riet implant. But realize that the revision rate, as we heard today, is very high.
Thank you so much.
Well, thank you very much, Jagwant and Sjaak and Denise, for your answer. I think there's still a lot more questions and unknown answers regarding the radial head. Please keep posting them in the Q&A section, because next session at the Munich conference, we will be having a shared session again on the symposium with EUSSER and SECEC, and we can maybe keep on deliberating about those questions on the radial head. So we move on to the next part of this webinar, which is about the total elbow arthroplasty. Jagwant was sending me a WhatsApp in between. I was a bit distracted. Graham King will tell us all about the updates on the current knowledge on elbow arthroplasty. I'm sorry for the miscommunication. Graham King is coming from London, Ontario, and well, as far as I know, Graham is always busy with elbows, so he will enlighten us on the updates in primary total elbow arthroplasty.
Good evening. My topic is to discuss updates in primary total elbow arthroplasty. I do have relevant disclosures in that I'm a consultant for Stryker and receive royalties for a total elbow design. The Australian Joint Registry has shown us that the indications for total elbow arthroplasty are changing. There's an increase in use for primary trauma, osteoarthritis, and a reduction in the incidence of use for rheumatoid arthritis as disease control improves with better medications. We now know that the risk factors for aseptic loosening are related to patient factors such as younger patient age, high BMI, male patients, rheumatoid arthritis, and patients with an opioid use disorder. There are many prosthesis designs to choose from. However, most that were initially invented are now no longer commercially available. With respect to unlinked total elbow arthroplasty, these require the presence of good bone stock and ligaments. They require the surgeon to accurately place the implant to avoid instability. They theoretically should have lower loosening rates than a linked arthroplasty, but this has not been proven, and instability when it occurs can be problematic. These are generally no longer widely available, and only currently in most countries convertible implants are options. We know that linking a loose hinge total elbow arthroplasty does increase implant loading. As you can see here, when this implant was linked, the forces went from the blue lines to the red lines, suggesting a significant increase in forces on the bone cement interface, and hence a theoretical increase in loosening risk when an implant is linked. We know, however, when unlinked implants are used and there is no radial head, there's a tendency for failure in valgus loading, as you can see here in the Sorby total elbow, and this causes edge loading of the components. This has been reported recently with the IVP implant, where polywear and metallosis tends to become a major issue after increasing years of clinical use. Native or radial head replacement should improve the stability and wear of an unlinked total elbow arthroplasty by improving load transfer and offloading the medial collateral ligament, avoiding that ligament's attenuation over time. The clinical problem has been, however, that a reliable radial head has not been developed for total elbow arthroplasty, and most have been problematic in clinical use. These implants, however, can work. Here's one of my own patients 20 years after total elbow arthroplasty, and it's still functioning well. The bipolar implant radial head used in this design was suboptimal, and we had a lot of early failures with disassociation of the head from the stem. Why did the radial head fail? Well, it turns out there's actually distraction forces which occur across the radiocapitellar joint when the arm is in varus. Secondly, the pull-off force or the linkage of this implant was quite weak with only a 97 Newton failure rate. This design has now been improved to increase the pull-off force to 2,000 newtons by compressing a peak ring around the implant to prevent dissociation and essentially turning it into a linked device. We've also focused on improving stem fixation, but we really don't know if this is going to perform any better than our prior device. Instability of an unlinked total elbow arthroplasty is a challenging clinical problem when it occurs. This is the reason why many surgeons have moved away from using unlinked implants, because revision was quite difficult, requiring removal of the stems. With the advent of convertible total elbow arthroplasty, revision of an unstable unlinked arthroplasty becomes quite a bit easier, and therefore may increase the indications to use an unlinked device. As an example here, this is a 70-year-old woman with osteoarthritis who had failed prior debridements, including an outerbridge Kashiwagi procedure. 6 months following her unlinked total elbow arthroplasty, the patient complained of pain and clunking. When performing an examination under anesthesia, you can see that the medial collateral ligament did not heal, and the lateral collateral ligament similarly failed. The radial head, however, is maintaining stability, unlike our prior design. This was easily converted to a linked total elbow arthroplasty as an outpatient procedure through a small tricep splitting incision. Postoperatively, stability was restored, and the patient's clinical outcome has remained good. Our experience with the Latitude implant has been that the overall long-term outcomes have been similar between linked and unlinked devices. However, the patients are quite a bit different. As you can see here, the patient on the right would get a linked implant, and the patient on the left an unlinked implant. The unlinked implants failed early due to instability, and the linked implants tended to get aseptic loosening over longer periods of follow-up. With respect to linked total elbow arthroplasty, instability is prevented by the linkage mechanism, which allows for expanded indications, including such diagnoses as fractures, bone loss, tumors, and revisions. The concern, however, is the long-term risk of wear of the bearings and failure of the bone cement interface. We now know that linked semi-constrained implants have good results in low-demand patients at medium to long-term follow-up. Bearing wear remains the main issue with these linked devices. Polyethylene wear is the most common mode and is an important cause of osteolysis. This can lead to fatigue failure of the stems, secondary to bone loss. Bearing designs with newer implants have been improved. We compared 3 different designs here: a sloppy hinge, hourglass, and a concave cylinder in a finite element model. One can see here that the stressors were lower in the newer bearing designs, and hopefully this will lead to improved durability. Newer cross-linked vitamin E poly and a not modified bearing has decreased the linked in vitro wear of the new Nexel bearing compared to the Kunrad-Mori bearing. We don't know for sure if this relates to the polyethylene or the bearing design. Smooth stem total elbow arthroplasties have been shown to perform poorly due to debonding and pistoning of the stems within the cement mantle. We performed a study looking at surface treatment of smooth-stemmed implants and applied titanium beads or plasma spray on both cobalt and titanium stems. We showed that overall titanium plasma spray is the best surface treatment for both titanium and cobalt chrome implants. And this is what most total elbow implants now incorporate. When we look at the early results of the Latitude legacy device compared to the newer Latitude EV stems, we can see lower loosening rate with the new plasma spray coated stems. We're hoping this stands up in longer term follow-up. All commercially available semi-constrained implants have some type of surface treatment, at least those available in North America. This is a patient that had an XL total elbow arthroplasty for fracture at the age of 72. 3 years later, you can see she had loosening of the humeral component, which is quite surprising given that she is not a high demand patient. There have been variable reports of the outcome of the NexL total elbow. You can see here that in Mori series from Mayo published in 2022, they had a 36% revision rate at 2 years. However, more recent data is much more positive. Ahmad reported 38 patients with only a 5.3% loosening rate and the need for only 1 revision. It was postulated that impingement of the coronoid on the humeral component may be a cause of this higher failure rate, or perhaps backside wear of the NexL bearing against titanium. Data from the New Zealand Joint Registry shows much better results than reported by Morey. However, there still seems to be a bit of a trend for higher failure rate of the NexL compared to the Coonrad-Morey, but more follow-up will be information is required. Overall, the Australian registry shows significant differences in outcome between the indications for a total elbow arthroplasty. When the total elbow is placed for osteoarthritis, it has a higher failure rate and a lower failure rate when it's used for primary trauma. However, when we look between implants, the failure rate seems to be quite similar, and it's disappointing that we're not seeing an overall major improvements in survivorship with the newer designs. So in conclusion, I think the role for unlinked total elbow arthroplasty remains unclear. Newer total elbow arthroplasty designs may have improved durability, but this remains unproven. Future developments should be patient-specific uncemented implants, patient-specific guides, and perhaps guidance systems or the use of virtual reality or robots to help us get better results with our total elbow arthroplasty.
Thank you very much, Graham. So there's still a lot to learn and to research, and the future looks bright for the total elbow arthroplasty, which will we have not seen the end yet. The next speaker will be Joaquin Sanchez Sotelo. He is from the Mayo Clinic in the United States.
Good evening, and thank you for the opportunity.
And the video already started. I wanted to say thank you very much, Joaquin. Joaquin will be the next upcoming president for the American Shoulder and Elbow Surgeons, so we're in a good position with all elbow and surgeons, presidents from everywhere. So Joaquin will enlighten us how we're going to revise a total elbow arthroplasty.
To participate in this wonderful SECEC webinar. These are my disclosures which are not relevant for the content of this presentation. When we approach a patient with a failed elbow arthroplasty, there are a number of items to be considered, including the possibility of a deep infection. Are the nerves located in an anatomic or non-anatomic position, and what's their condition? Is the triceps functional? Which are the implants that failed? And which will be our revision strategies? One challenge sometimes is removal of well-fixed implants. Our workhorse is the use of a pencil tip burr that allows careful debonding of the implant, cement and bone interface before safe component removal. On the humeral side, when the implants are well fixed, sometimes it is possible to remove them using a vertical corticotomy, but occasionally it is necessary to create a posterior window that can then be replaced at the end of the procedure. On the ulnar side, especially when there is infection and we need to remove all the cement, it may be useful to perform an extended olecranon osteotomy, where the medial cortex is divided with a saw, laterally perforations are created, and the dorsal cortex of the ulna is mobilized laterally to remove the implant and the cement. This can then be repaired with circumferential wires or sutures. There are multiple revision strategies that may be considered at the time of revision elbow arthroplasty, using a longer cemented component, impaction grafting, strut augmentation, allograft prosthetic composites, modular replacements, and very rarely permanent resection or amputation. Impaction grafting was first reported at Mayo Clinic on a series of 12 patients. And the key is to use some type of trial that can be placed in the canal so that cancellous allograft chips can be carefully impacted to recreate a neo layer of cancellous bone that will provide adequate stability for a cemented component. And this is ideal for contained cavitary defects. Strut augmentation was developed mostly for the management of periprosthetic fractures with a loose component. You can see an example where a fracture around a failed prosthesis is managed with revision arthroplasty using anterior and posterior spluts and supporting the flange. In 2002, we reported reasonable success rate in a total of 11 cases treated with this strategy. And we noticed that the strut tends to heal, especially at the periphery. Similar positive experience was reported by Dr. Camineni in a series of 8 patients also treated at Mayo Clinic. Here you can see an example of a patient with a failed ulnar component with very thin cortices, where the revision involved placing of a longer cemented stem but also augmentation of the cortex with a strut, as can be seen in these postoperative x-rays. Allograft prosthetic composites are considered in patients with more substantial bone loss. However, early on, the reports were not very promising, and in fact, Drs. Mansat and Mori recommended the pursuit of other revision options. One challenge is that when patients use the upper extremities to hold heavy objects, there is a rotational torque that can really compromise humeral fixation. One other challenge is that when the triceps is insufficient, patients don't do well. This patient has a well-functioning triceps after her right total arthroplasty, but not so much on the left, where she is unable to perform other head activities because of triceps weakness. We know biologically it is extremely difficult to re-establish the enthesis between the triceps and the bone. And for those reasons, at Mayo Clinic we migrated to use a proximal ulna with triceps allograft. The combination of compression plating and the use of a graft that has bone for the ulna and tendon for the triceps has been successful. The technique involves preparation of the ulna on the back table, compression plating of the graft to the host, linking the prosthesis, and then repairing the triceps muscle of the patient to the triceps tendon allograft. In 2001, we reported a small number of patients treated with this strategy. We had a total of 10 cases performed by myself. And when surgery worked, patients did well in terms of motion and pain relief. And in addition, mean triceps strength was restored to 4 out of 5. Of course, this complex surgery is fraught with complications. Here you can see a patient with failure of both the humeral and the ulnar components, treated with APC reconstruction of the distal humerus and proximal ulna with triceps. X-rays after surgery show adequate restoration of the skeleton. But more importantly, in clinic, one can confirm that 3 or 4 months after surgery, the patient has an intact extensor mechanism with adequate strength and extension, and even the ability to straighten his elbow overhead. Humeral APCs, unfortunately, have been less successful. The principles of humeral APC reconstruction include length restoration, compression plating, and adequate junction. We just reported the outcome of a number of patients that we treated at Mayo Clinic. A total of 41 elbows that all underwent reconstruction with a humeral APC with compression plating. Even though patients did well clinically when the reconstruction worked, we confirmed a 36% rate of non-union. And of course, it's really disheartening for both the patient and the surgeon to spend hours trying to reconstruct the distal humerus with an allograft prosthetic composite to then witness failure. We did learn that maybe we will have better outcomes if we can either use interoception or maybe a strut-like extension of the allograft that provides better surface for allograft to host healing. However, it is tempting to migrate on the humeral side to humeral metallic modular replacements. This is one example from my practice where we manufacture the component with features in the stem to provide rotational stability in the cement mantle as well as an anterior flange. And 4 years after implantation, this patient is still doing well clinically and radiographically. So now when we see that a patient has a risk of failure for allograft prosthetic composites, we consider the design of this type of components that have special features in the stem and anterior flange, and lately screws that come from posterior to anterior and can hopefully impart better rotational stability. You can see an example of the trial and the implant, as well as the images obtained intraoperatively with fluoroscopy and post-op X-rays. Very rarely there is very limited proximal humerus bone left, and in those cases we have reported approaching the elbow from a long deltovertebral approach and using modern periarticular humeral plates for fixation, which can help restore function in patients with very difficult situations. So in summary, failed elbow arthroplasty requires to rule out infection, assess the condition and location of the main nerves of the upper extremity, assess and address the triceps if it's dysfunctional, understand which are the implants that failed, and contemplate a number of revision strategies. These may include longer cemented components, impaction grafting, strut augmentation, APCs, modular metallic replacement, and very rarely permanent resection or amputation. Thank you very much for your attention and have a wonderful rest of the evening.
Thank you very much, Joaquin. Very illustrative videos and images of, well, impressive surgery, it would be my opinion. The next speaker will be Adam Watts, coming from Wrightington in the UK. And Adam will tell us all about how to use total elbow replacement and hemiarthroplasty in the case of trauma of the elbow.
Hi, good evening everybody. My name's Adam Watts. I'm an elbow surgeon from Riet Hospital in the UK, and it's a great pleasure to join you for this symposium. I've been asked to talk about total elbow replacement and hemiarthroplasty for trauma. These are my disclosures. Relevance to this subject is my association with Stryker, and I'm paid for educational activities for use of the Latitude implant. So if you're faced with a 69-year-old female patient who enjoys gardening and has this low energy fracture of the distal humerus, also involving the sublime tubercle, we need to ask ourselves the question, what is the best management for this patient? There are lots of options available to us. You could use a bag of bones and treat them non-operatively in a cast for between 3 and 6 weeks. Just let everything stiffen and then get them moving. We could undertake osteosynthesis. We could do a total elbow replacement or a hemiarthroplasty. It's an important question because the number of these cases is increasing over time, and all of us in Western countries are going to see a greater demand for this type of injury and requirements for treatment, whether it be hemiarthroplasty or osteosynthesis or total elbow replacement. We are definitely seeing a change in the UK. If you look at the yellow line, this is the trend for elbow arthroplasty for trauma, which has doubled in the last 10 years. The question is, when should we consider replacing the elbow rather than just fixing it? The things that I tend to look for on the CT scan is a very low fracture line, obviously intra-articular involvement, but fracture lines that exit below the ligament insertions. I'm looking for eggshell fragments. Those are fragments where there's very little bone behind the subcortical, subchondral bone. And I'm looking for triplanar injuries, so this is multi-planar, multi-fragmentary fractures. And those I think are then very difficult to fix, and you can anticipate that bone quality will be poor. We have a randomized controlled trial of a limited number of patients with quite a high crossover rate of 25%, but this study did show benefits to total elbow replacement over osteosynthesis in elderly patients. Looking at the longer term follow-up of the same study, I think it's really important to note the number of patients that were deceased, so 15 in the arthroplasty arm, 10 in the osteosynthesis arm, not from the surgery, but from just anno domini and the fact that this is a pre-morbid injury. If we look at reoperation rates and revision rates, it seems that total elbow replacement has an advantage over osteosynthesis in this patient group. Does it matter if we try to fix it and then go on to do a total elbow replacement if it fails? Well, Prasad showed that the outcomes were not statistically significant, but with a revision rate of a survivorship rate of 76% in the delayed elbow arthroplasty group versus 93% in the primary, it does make you worry that there may be an effect visible here with a larger case series. Our enthusiasm, however, for undertaking elbow replacement may be tempered by the long-term complications as reported from the Mayo Clinic, with reoperation rates of 31% and complication rates of 40%. So there's a newer alternative, hemiarthroplasty, which actually in the United Kingdom has overtaken total elbow replacement for treatment of distal humerus fractures, with more than 50% of arthroplasties being hemiarthroplasties. What are the advantages of hemiarthroplasty? Well, it's a quicker operation. It's stated that there's no limit to function after a hemiarthroplasty. It's bone preserving, and the other argument is that it avoids the complications of the ulnar component. But it has potential disadvantages too. There's possibly a greater risk of instability, certainly compared to a linked arthroplasty. We have seen problems of erosion of the greater sigmoid notch from a hemiarthroplasty. And there's the as yet undefined issue of ongoing pain after a hemiarthroplasty, which may be a lesser risk in a total elbow replacement. Both can be done through a lateral parallelecron or a triceps preserving approach, and this is important in order to balance the soft tissues. An elbow replacement, whether it be a hemi or total elbow, is a soft tissue procedure, and we need to make sure we restore the axis of rotation, looking at the vault of the olecranon fossa to guide us, and the tension in our intact triceps to tell us whether we've got the elbow in the right position, in the right position. The important thing, however, is that a hemiarthroplasty is less forgiving than a linked total elbow replacement, because if we get the balance wrong, or we don't repair the soft tissue stabilizers adequately, then we will run the risk of instability. Rotational alignment is important, whether we are doing a hemi or a total elbow replacement, but arguably with a total elbow replacement there are more components to get mal-rotated. And of course the cement mantle is very important in terms of making sure that we have complete whiteout by using cement restrictors proximally, by retrograde filling of the canals, and using a pressurizer. And I use the bung off a 50ml syringe as my pressurizer around my narrow nozzle cement introducer, and I find that works very well. What do we do with the condylar fragments with hemiarthroplasty? You can spend time undertaking osteosynthesis of the condyles with plates or with screws. McKee has shown that with total elbow replacement you could actually excise those fragments without altering the function of the elbow, although the patients tended to dislike the narrowing of the elbow that occurred when you remove those condyles. In my practice, I prefer to use sutures to repair the condyles, repairing the ligaments through the spool, and occasionally using sutures between the fracture fragments and the main shaft of the humerus, or around the yoke of the humeral component. And what we found is that in the vast majority of cases these unite with callus formation. Over 90% of them go on to union. Where they don't unite, we haven't seen any problems or complications associated with that. There's no problems of instability or pain that we've witnessed in association. So this is less patient with a non-union, but a very satisfactory outcome, good range of movement, and a pain-free elbow. So the question then remains, well, who is a hemiarthroplasty for? Is it for all distal humerus fractures that are unfixable? Should we be using it in younger patients in preference to total elbow replacement? Or should we be saving it for the more active elderly patients or frail older patients who have low functional demands? If we look at who is currently getting elbow replacements, this is from a systematic review of the published literature, we can see that the demographics very similar between total elbow replacement and hemiarthroplasty, but with a longer tail to the younger age group, suggesting that maybe with the hemiarthroplasty we're less likely to try to fix and reach for the arthroplasty option as a bailout. If we look at the functional outcomes, so there are several systematic reviews that have been undertaken. This one from Stanmore shows that there is no no difference in the functional outcome with hemiarthroplasty, total elbow arthroplasty, or osteosynthesis. And interestingly, from the review of the literature, no difference compared to conservative treatment either, except that the one with the lowest reoperation rate, of course, is those having treatment with conservative treatment, which does give you pause for thought, although this is a selected group of patients and not a randomized controlled trial, and we should be very careful in interpreting that data. A group from Exeter looked at the similar data and concluded that functional scores were in favour of hemiarthroplasty over total elbow replacement, but neither of these systematic reviews looked at the effect of or looked at pain outcomes following hemiarthroplasty and total elbow replacement. And we've recently completed a systematic review, of which the most important take-home message was that in the distal humerus hemiarthroplasty group, based on currently available literature, there appears to be over 10% risk of moderate pain ongoing after that procedure, which we didn't see from the total elbow arthroplasty literature. But again, this is not a randomized controlled trial, and the data should be interpreted with caution because of the risk of bias. So, what is the reason to do a hemiarthroplasty? Well, is it a quicker procedure? I'm not sure it is. I think by the time you spent time getting the soft tissue balance right, repairing the soft tissues, it probably takes a similar length of time to a elbow replacement, especially if you're doing a linked elbow. The question regarding limits to function, really that's down to what we tell the patients and what the patients decide to do. We know that most patients after an elbow replacement don't restrict their function, and that's an even higher proportion in those who have elbow replacements for trauma. So I think that argument probably doesn't stand a test. It is bone preserving. I think we can definitely say that we're not running into removing bone from the ulnar side of the joint. However, we may over time see problems of bone erosion, and we can definitely say we can avoid the problems of the ulnar component. However, when we look at revision rates from the National Joint Registry, the revision rate for hemiarthroplasty is higher at 2 years compared to total elbow replacement. Now, the numbers are very small. This is probably not statistically significant, the difference that we see here, and it probably reflects a learning curve, and we may see this change over time, but it does give pause for thought. Are we doing our patients a service by switching to hemiarthroplasty over total elbow replacements or not? And we need to think carefully about that. One of the things we have learned from hemiarthroplasty is that you, just because it's trauma, you don't have to link your replacement, and so an unlinked total elbow replacement can be done in trauma, and we have good experience of that at Wrightington. So who is a hemiarthroplasty for? I don't know. In honesty, I don't know which patient group is best served by a hemiarthroplasty. In my practice, given what we currently know about the outcomes, my preference is to use hemiarthroplasty for more frail, low-demand patients in whom they don't seem to experience pain and they're quite happy with the outcome. If they're younger, active patients, my preference is to use a unlinked total elbow replacement, and if they're young, I try and do my best to fix, even if that fixation may be less than perfect. They may be better off with that than with an arthroplasty in the long term. There is one group where we definitely know that a total elbow replacement is better than a hemiarthroplasty, and that's the patient with pre-existing symptomatic arthritis, where there is a higher risk, of course, of pain from a hemiarthroplasty, and so most people would consider doing a total elbow replacement in that situation. The one thing we can comfort ourselves with is that if we do a total elbow replacement, we actually have lower revision rates than elbow replacement for elective indications. And we should be mindful of the 30% mortality rate at 5 years following an elbow replacement for trauma. So this is an injury that's typically sustained in patients nearing the end of life. And the long-term survival of an elbow replacement may be less of a concern in this group. Again, it's just another factor to weigh up in our considerations. So in summary, elbow hemiarthroplasty has overtaken total elbow replacement for treatment of distal humerus fractures in the UK. We do have some concerns about the higher revision rate. We have some concerns about the possible higher rate of pain. It is a technically demanding operation, and we have to ask ourselves who should be doing these operations. And also question, is the new kid really better than what went before? Are there some patients who benefit and some patients who may be better off with a total elbow? Thank you very much.
Thank you very much, Adam. Interesting talk, nice illustrations, and thank you for your honesty and being objective. And apparently there's still some questions to be answered in the future if hemiarthroplasty is the way to go. There's still room for questions at the end of this session, so please keep filling in your questions at the Q&A session. As said before, we're surrounded by future presidents of societies and current presidents of societies, because Val Jones is the last speaker of tonight, and she's the current president of EUSSER. And she will tell us all about rehabilitation following total elbow arthroplasty, and she's from the UK. Thank you very much, Val.
Hi, my name is Val Jones, and I'm lead physio for the Sheffield Shoulder and Elbow Unit, and also the current president of EUSSER. And I'm going to talk about rehabilitation following total elbow arthroplasty. So if this is an elective procedure, preoperatively, we like to see the patient wherever possible. We're going to educate patients and their carers about what the surgery entails, because this can help patients in terms of expectations, but also post-operative satisfaction. And also we can talk to them about any restrictions that may be placed on them in terms of lifting weights in the future. We can also screen them for issues that would delay discharge, such as mobility issues, walking aids, or even occupational advices and aids and adaptations to allow them to return to as normal a function as possible after their elbow arthroplasty. In terms of post-operative rehabilitation, we need some key information from the surgeons. So communication with the surgical team is absolutely vital. We need to know, first of all, is this procedure being undertaken as for trauma, or is it an elective procedure, and is it a primary or a revision, as our rehab tends to be a lot slower with our revision procedures. We also need to know about the type of prosthesis. Is it linked? Is it unlinked? As this is always going to have an impact on varus and valgus stability in the future. The hemi and the unlinked prosthesis, we have more restrictions initially to avoid initial instability, because they rely very much on soft tissue continuity in terms of collateral ligaments to provide that stability, but have fewer long-term restrictions in the future. We also need to know about whether triceps is on or off in terms of surgery and surgical approach, as again this will influence our immediate rehabilitation for the patient. We need to know, really importantly as well, what range of motion was achieved on the table at the end of surgery, as again this will help guide us as to what future range we're going to achieve with our patients during the rehabilitation process, so we can set realistic goals and expectations with these patients. We also need to know about soft tissue preservation and periarticular muscle function, because again that's going to help us in terms of guiding our rehab strategy. And this has been seen by this paper here in 2019. Long lever flexion or abduction of a weight more than a few kilograms caused plastic deformation, especially in the Coonrad-Maury prosthesis compared to the Nexel and Discovery systems, probably because of the smaller surface area contact, which was the loads placed upon it were enough to cause plastic deformation. So immediate rehab for our unlinks or our hemiarthroplasties is sling for comfort, possible splinter gain initially to help again with comfort, and as I said before, the aim of initial rehab is to protect that collateral ligament complex. So we're going to start in the overhead position with active motion, not passive, as passive may confer increased stresses upon those collateral ligament complexes. Active will actually decrease those stresses, and again we're going to avoid those long lever movements into varus. But what's really happening out there? Well, this is a survey of SECEC members that showed 52% immobilized tricep sparing, and my answer will be why. The idea is with the tricep sparing, triceps on approaches is to get the patient moving as soon as possible, and 65%, almost 2/3 of surgeons responding from this questionnaire, immobilized with the triceps detached. The surgeons put a removable cast on anywhere between 1 and 40 days. However, they did allow passive movement immediately, and again, knowing that this can actually increase stresses placed upon the healing collateral ligament complexes, my answer to this would be why. Why not allow active movement in the overhead position, because it's going to be actually safer for our healing tissues. So, is there any consensus really on rehabilitation after total elbow or hemiarthroplasty? And the answer is pretty much no, looking at this systematic review undertaken. The only thing that they actually agreed upon was no casts. And we certainly within our unit minimize the use of casts, or if they are used, are only there transiently. We try and start active movement as soon as possible. And I think there are other downsides of putting casts on patients who may be of advancing years, certainly because of things like balance reactions compromised. We know that if you immobilize an upper limb, especially the dominant upper limb, then you can actually influence posture, postural sway and balance reactions in a negative manner, reducing balance reactions by up to 1/3, which could therefore lead to more falls, and obviously a fall and its implications upon a total elbow replacement could be huge. We also need to remember that elbow joint proprioception is down already, and it's even worse after a total elbow arthroplasty, as shown in this study. So what we as physiotherapists need to do is remember strategies to improve sensory input. So this can be via the cutaneous receptors, which have been shown to be hugely influential in elbow joint proprioception. So we'll use the use of tape or a compressive elastic bandage or an elbow joint sleeve. We can also use touch to guide patient movements, because again, that's going to be stimulating those cutaneous receptors. We can use visual imagery such as mirror work and functional multi-joint sequences. Upper limb and elbow proprioception improves when we use multi-joint, so using the hand to actually hit a moving target. So in the overhead position, you can actually get a patient to tap a balloon overhead. That will improve elbow joint proprioception more than just straight flexion, extension and pro and supination movements at the actual elbow. And we're always going to encourage the patient to use the hand, because remember, the brain thinks the hand is really important, and the elbow and shoulder are there to serve the hand to place it anywhere it wishes to go. We're also going to improve patients' outcomes, hopefully, by using graded motor imagery. So graded motor imagery techniques such as right and left discrimination. So this is an app that you can use. It's called Recognise, and it costs a few euros for patients. However, there are other free ones called Orientate, and this in conjunction with other graded motor imagery strategies such as mirror therapy and 2-point discrimination has been found to increase range of movement after elbow trauma compared to just using elbow exercises alone. So I'll use my exercise strategies, but I'll also use the graded motor imagery approaches as well. I'm also, as soon as possible, going to encourage the patient to use their contralateral upper limb in terms of strength training, because using heavy strength training on the good arm, as it were, the unoperated arm, has been shown to maintain cortical excitability, cross-sectional area and strength in the forearm muscles in the immobilized upper limb. So we need to get our patients working both sides, and of course if we see the patient preoperatively, we'll advise them upon this. So we're also going to change the narrative. So I think it's really useful, as we said before, to use things like a balloon as a target practice, and we get the patient to focus on moving a balloon rather than focusing on moving the elbow, as it reduces anxiety and changes the narrative almost. So for this lady here who's had a hemiarthroplasty, we get her to squeeze the glove, a water-filled glove, rather than just concentrating on flexion exercises alone. So a target or a change in focus can be really usefully clinically, and you can make them functionally relevant as well. How do we progress? Well, we're going to incorporate bilateral movement, kinetic chain recruitment, as adding a lower limb step increases upper limb muscle activation, and hopefully our patients are going to be functional by 8 to 12 weeks post-op. We're also going to warn the patients about appropriate functional limitations such as low demand dexterous activities, refrain from driving for a minimum of 6 weeks. However, we do know there is no consensus on appropriate loading, but within our unit we say we allow low load gardening, swimming, but to avoid high demand activities and jarring activities such as boxing, chopping wood, golf, etc., and other lifestyle factors, certainly trying to maintain their body mass index in a healthy range. But what really happens? Well, we know from this study that patients remember that they were given advice to avoid high demand activities, but especially males and those who've had an elbow replacement for trauma actually undertake moderate or high demand activities. So in order to avoid potential loosening, what do we need to do? Well, we need to think about the type of load, the type of movement, and also the frequency of movement cycles. And in the past, we've always told patients to refrain from lifting weights on an intermittent basis for more than 5 kilograms. However, there's actually no concrete evidence to support this, and it was really interesting, this recent study that showed that steering a car wheel was actually, in terms of joint reaction forces, almost similar to pushing up from a chair. So I think there needs to be more work done to actually see what are a safe, functional, appropriate limitations for patients. So in conclusion, there's little consensus so far, which we certainly need to work on with both surgeons and therapists in terms of the optimal post-operative rehab regime, and we need further work into what is safe functional loading for patients following total elbow replacement. And I'd like to thank you for your attention, and I'd like to thank SECEC for collaborating with therapists in EUSSER to make sure this is a truly multidisciplinary event. Thank you very much.
Thank you very much, Val. It was a great overview and great talk, very thoroughly as always. We're going to now do the Q&A questions. Joaquin is still with us, but he needs to leave within 5 minutes. So the Q&A session will be done by Solenn again from France, and Angelo di Giunta from Italy, Sicily. They will ask the questions, but so maybe if there's a question first for Joaquin, please address them to him. Go ahead.
Okay, thanks a lot, Tjarco. There is one question to hold the expert, what's your preferred attitude after hemiarthroplasty for trauma with early ligament failure instability? Do you perform systematic revision with total? Do you try one Riet for a ligament or resuture? This is for all the experts, and I think I will make the first one to Sotelo. So I heard that he need to run. So please, thank you.
Yeah, so for me, if a patient, I have mostly seen unlinked, unstable total elbows as opposed to an unstable hemiarthroplasty. But if I had a patient that had a hemi for fracture, like Adam showed in his great presentation, and the patient became unstable, I would probably revise that patient to a linked total elbow as opposed to trying to reconstruct the columns and do something that is probably unpredictable. That would be what I would do. I don't know about Dr. King and Dr. Watts.
What about the rest of the presenter? Dr. King, Dr. Watts?
Sure, I can make a comment on that. Actually, I've not had any of my hemis be unstable yet, so I'm not sure why that is. Probably because I'm a little more OCD than others in terms of fixing the bony and ligamentous structures. One of my partners has had one instability case. I think, you know, if the patient was doing something incorrectly and they had a subluxation episode, I think I might just try, you know, a reduction and splinting and get Val to help me with overhead rehab protocol and see if I could just get them to settle down. We've certainly seen that in some unlinked arthroplasties in the past with early subluxation. But if this was a more late phenomenon, I agree with Joaquin. I'd probably just convert it to a linked arthroplasty. But again, fortunately, I haven't seen it yet, but I'm sure it will see me soon now that I've said that.
I agree absolutely, Graham, that I think if you get in there early, so if it's an acute dislocation early in the recovery after the initial surgery, then there's a good chance that you can restore stability by re-repairing the soft tissue collaterals, assuming that the implant has been put in correctly, that it isn't malrotated, and that there isn't some other reason, such as a coronoid fracture, that's led to the instability. But if it's a later or more long-standing subluxation or dislocation, the soft tissues all tighten up, the triceps becomes contracted, and actually just bringing the forearm back under the distal humerus can be very challenging. In that situation, I would definitely convert to a linked total elbow replacement. The beauty, of course, with the latitude system is that you can leave the stem in and just change the spool from a hemiarthroplasty to an arthroplasty spool and put an ulnar component in with a cap.
Okay. Another question. Dr. King, do you start replace the native radial head with a radial head prosthesis when performing total arthroplasty?
Well, maybe I didn't get the question right. Do I always replace the radial head when I do a total elbow? Is that what your question was?
Yep.
Yes,
Yeah,
yes.
Typically, I don't actually. I look at the native radial head and say, well, is that a good radial head? Is that worth keeping? Certainly in trauma, I always keep the native radial head. Some patients with osteoarthritis are good candidates to maintain the radial head, but I find more of my rheumatoids, there's a significant radial head disease. So if they're more involved or they have symptomatic radiocapitellar pain, then those are the ones I typically will put in a radial head implant. Certainly, if I'm going to do an unlinked arthroplasty and the radial head is unsuitable, I always replace the radial head in that situation. I try not to do an unlinked arthroplasty without a radial head. I have had some success doing that, but that's not my preference. And typically, you know, with the newer radial head, we feel more confident in its performance, at least so far, but we also thought that early on in our other implants. So we'll see, but we're being a little more aggressive, I would say, at replacing the radial head now than we were when we had our former implant. I don't know if Joaquin can comment on that.
Yeah, I feel the same way. You know, the second generation implant, and I myself don't have a conflict of interest, so I can speak freely. is a very good implant because of what Dr. Kim mentioned of better finish of the surface of the stem and a much better locking mechanism. So I tend to replace it also, especially if I'm going to do an unlink with a short stem and the radial head has any deficiency. I think having that lateral column load sharing is very useful. So I've been very impressed with the performance so far. We actually have a paper accepted for SECEC reporting on the early outcome of this newer implant, and we have had basically no failure so far.
Thank you very much. Solenn, have you maybe got a question on rehab?
Question for Val. How long after surgery can you start strengthening the muscles? And what is the minimum range of motion required to start strengthening muscles?
It's not so much range. We would usually start sort of low grade strengthening usually after about 6 weeks. So we focus more on functional range first and making sure that the patient's got enough to perform their ADLs. And even then it would only be light strengthening, low demand. The thing that we concentrate on lots is, this might sound a little strange in an elbow seminar, is lower limb strengthening, because we want them to avoid using their arms to push up when they get out of a chair and things. So I will have lots of 70 and 80-year-old ladies and gentlemen in Sheffield doing squats and things, so that they can actually, so that it looks like a gym class. So Angelo will be there doing her squats, getting her legs strong, so she doesn't have to actually use her arms to push up anymore. She can use her legs.
Okay, thank you, Val. So kinetic chain is very important for elbow rehabilitation.
Absolutely. We're not looking just after the elbow, we're looking after the whole person.
Obviously, as all good physios do. Thank you all faculty members, for your outstanding presentations. I think there's still a lot to discuss, and as said, please do ask them, maybe put them in the Q&A in Munich. In September, we will be having a symposium together with EUSSER again, and maybe we can go a bit deeper onto all those questions. Once again, enjoy your evening. Thanks for being here with us, and hope to see you all in Munich in September. Have a nice evening. Bye.